Okay, I think we're good to start. So I'll just introduce you to our group and then you can get started with your presentation. So thank you so much again for being with us today. Good morning, everyone. Today we're joined by Dr. Singh. She received her MD from Northwestern University, her doctorate in public health from the University of Texas School of Public Health, and a master's degree in maternal and child health from Harvard University School of Public Health. She currently works with Kaiser Permanente Integrated Care Delivery System, practicing integrative gynecological oncology, meaning that she utilizes both traditional approaches to treat her cancer patients, like surgery and chemo and radiation, but also integrates more holistic practices like lifestyle changes, mindfulness, herbal approaches, acupuncture, etc. She's been recognized time and time again for her medical excellence and her patient care, and she is the Vice President of Physicians for a National Health Program. So we are very honored to have her join us today, and she's going to be discussing and introducing the concept of single-payer reform. So thank you again, Dr. Singh.
Awesome. Thanks, Gabriella. So I feel like we're a small enough group. If stuff comes up during the conversation and you want to throw it into the chat, you can do that. And I'm hoping I left plenty of time. I am not with Kaiser anymore. I heard yesterday you guys were talking to someone from who's doing direct primary care. And I was thinking, like, so I'm doing locums these days. And so I'm traveling for work. But I think of it as one of the other ways that, like, I'm adjusting, so to speak, to our healthcare system to have it be something that can work in my life and still have the time to do things like participate in PNHP. But let's get into the facts and then we can kind of go from there. So saving lives and saving our healthcare system, I think they are both, oh, there we go. So I'm going to do a quickie, like 5 slides of kind of the basic information. And I'm going to do this talk kind of in 2 ways. I think you guys are self-identified as healthcare advocates. So I'm going to talk about it as in providing you the facts, but also thinking about different ways that we convey this information as we think about persuading people to help us explain how we see things. I think as physicians, we have a really unique space in the healthcare world that we don't always, I don't know how to say it, that we don't always optimize. So we'll go through the basics that we need, and then we'll get into more detail. I keep doing the wrong thing. There we go. So slide 1. The United States is the only developed nation that does not provide comprehensive health care to all. We have roughly 25.5 million uninsured. That was from 2022. The number's about the same, actually, right now. And then, even people who have insurance may not necessarily be able to access care because of what's called underinsurance, which is the idea that the coverage they have doesn't cover all their healthcare needs, or they can't afford to access it because of premiums and deductibles, or there are not specialists or physicians available to them to access. For example, I just moved up to DC from Norfolk. In Norfolk, took an average of 7 months to get an appointment with a primary care doc. I actually ended up never seeing a primary care doc down there because I just couldn't get it to work where they had availability and I had professional, time off or whatever, regardless. The other, I think, and this is why I have it in slide 1, like, we don't always think about not having coverage as a cause of death. But like this number, 37,000 roughly die a year from lack of coverage. And interestingly, like, that number falls right in between, I think, prostate cancer and ovarian cancer deaths per year. And I phrase it that way because, like, we would never say, like, you know what, ovarian cancer deaths, not a big deal. Let's just leave it at that. Our system can't handle trying to cure more people of ovarian cancer, which in a way is what we do when we say, oh, we don't think it's feasible to provide universal health care, or it's not politically doable, or we can't afford it. It's sort of we would never think of any other cause of death in such a sort of throwaway kind of way. And then the last thing, and that we are getting some bandage fixes for, is this element of personal bankruptcy being related to the lack of health care or underinsurance, in the sense that, you know, people get sick, they start accessing their care, and then because of their bills, because of their deductibles, because of their copays, because of things that weren't covered, ultimately they go into bankruptcy. And 70% of people who find themselves in this place had insurance at the time that they got sick. And there is, I think, currently a law that some of the legislators are working on to try to keep this from contributing to people's credit score, because it's so common now that being in debt for medical debt is limiting people's ability to do other things, right? Rent an apartment, buy a house, et cetera, et cetera. All right, slide 2. We have the most expensive healthcare system in the world. We spend at the very least twice as much on per person healthcare as the rest of the world. And yet we have worse health outcomes and we don't cover everybody, right? So we're like kind of covering none of the bases, and we'll talk in detail about the worst health outcomes. In the middle of our system, we have these third-party entities who don't bring anything to the table and who take roughly 30 to 35 cents of every healthcare dollar in a combination of profit and bureaucratic waste. It's about $1 trillion. And if we took that $1 trillion and brought it back into real healthcare, we could literally cover everyone and add mental health, dental health, vision coverage, decrease out-of-pocket payments, do a whole bunch of things. Even in a way like the term like healthcare insurance is a misnomer, in the sense that it's not insurance from the perspective of like, I'm getting, you know, car insurance in case I'm in an accident, assuming that I'm most likely not going to be in an accident, versus we want people to access their healthcare for preventive care, right? We want everyone to get their flu shot and their pap smear and their vaccines and their mammogram. And so it's something we want everybody to use, not just in the rare case of a fluke or uncommon, happening. The other thing is that, you know, we forget that we all benefit when everyone has healthcare that's unconnected to employment, right? Not only thinking of it from a pure quality of life, you know, perspective, but also thinking about the financial and creative freedom that people have when their employment is not a source of their healthcare coverage. And I hear it all the time, people who are frustrated or unhappy in their work, but they're afraid to lose their healthcare coverage, and so they stay where they are. Same as thinking about businesses, both small and large, where in the United States, one of their biggest expenses is having to provide healthcare coverage. And, you know, unions have spent so much of their time and energy jockeying and negotiating around trying to get good healthcare coverage. And then, of course, like this idea that like the marketplace is just a good thing, right? You know, we're seeing some flaws in the marketplace, even in the most private of private worlds now, with some of the anti-trade stuff going on. But even within like a perfect market, healthcare is not a great commodity, because there's this thing called information asymmetry. And that's like, you don't actually know what you'll need, right? My patients don't know that they're going to get ovarian cancer. And the truth is, like, that's a 1 in 70 chance. And so why would they research access to gynecologic oncologists or other things? And then there's no time to shop, right? Like, you have a mass, someone sees on CT, you need to get to a physician. You don't have time to shop around. And at that point, it's not when you're actually shopping around for your healthcare insurance. You already did that because you signed up for that months ago. This physician challenge part of it, and this idea of, you know, ultimately what makes our jobs wonderful is the ability to take care of people and to help them understand their bodies, help them understand what's happening with them, help them make decisions about what care they would like to receive. what makes sense for them. But as soon as you like introduce something else where, well, maybe we need to decide what's best for Kaiser or what's best for United Health or whoever I work for. And then thinking really hard about, well, I don't know if this person's insurance covers a PET scan, and I don't know if this person's insurance covers, Zofran or shots to keep people's blood counts up, what we call GCFF or bone marrow stimulating things. And like all of this part of medicine where it's not saying what's the best treatment, what's the best thing for this person based on their goals and their concerns. Instead, we're making decisions that are not driven by healthcare needs. And the thing that we've given up as physicians is autonomy, and that somebody else is making decisions for us. There are a billion people between us and patients when it comes to like the sanctity of the physician-patient relationship. It's kind of insane to imagine that a lawyer has more privacy with their patient than we do. And then there's the patient trust aspect, right? Of patients kind of recognizing that you might have a financial investment in what recommendations you make to them, whether it's you're a nephrologist who owns your dialysis or your annual bonus is based on how much time you spend with the patient or what recommendations you make or don't make. And then, of course, like the limited time with patients, right? The burden of the electronic billing records, the time we spend on complex coding, pre-authorization, dealing with denials, all of those things add up to this not being the wonderful calling that it could be. I cite this book, If I Betray These Words, and the concept of moral injury, that Wendy Dean and Simon Talbot were the people who sort of first brought this language that comes from the military into the medical world. And it's this idea of knowing what you need to do for your patients and not being able to do it. And really the challenge of like, we call it burnout, and we develop all these like self-care courses and all these other things, sort of implying that it's like as individuals that we don't have the capacity to deal with these things, which most research speaks against, right? That as a group, physicians have a lot of resilience. You know, someone like me who goes into oncology, someone who goes into trauma care, someone who goes into psychiatry, none of us thought there wasn't going to be mental illness, you know, patient loss and patient death, you know, complicated trauma cases of people being, you know, losing people in the OR. All of us as specialists or primary care docs, we knew that this was what we were coming to and that there would be challenges with it. But that's not what contributes for most people to burnout and for them to make decisions to change the way they practice or if they continue to practice. So solutions, there's a bunch of different words to use for this, and that's a whole different conversation, but we sort of generally talk about it as approved Medicare in the sense that that's the one place that we as a country or as a public are used to thinking about everybody just gets access automatically when they're 65. So all medically necessary care, right? Inpatient, outpatient, drugs, mental health, vision health. It's kind of crazy to think dental health is not part of our health. You know, one of the things we used to do back in the day was before we started chemo, like everybody got dental clearance. Why? Because you can get staph infections when you're immune suppressed. And if it's something easy to care for, you prevent it. And then, of course, we'll talk a little bit about comprehensive reproductive care. I'm just watching the time. No copays, deductibles, or premiums. No need for supplemental insurance, and this is a big issue currently in Medicare, where for traditional Medicare, just to get coverage for copays and deductibles, most people have to get a Medigap plan. It's what makes, for a lot of people, traditional Medicare unaffordable and why they end up with these Medicare Advantage plans that limit their networks and limit their care. And then equitably funded. We know that the burden of a lot of healthcare costs fall on the people who can least afford it. Sorry, here we go. But just like a little bit of background, like how did we get here into this crazy space and, what went wrong, so to speak? I mean, I think there's challenges in a lot of ways. Some of the roots and the ongoing history of the opposition to universal health care are, I'd argue, racist, sexist, and classist, right? Originally, the AMA opposed Harry Truman's plan when he wanted to do universal coverage, and then we ended up with Medicare because they didn't want to provide health care to non-whites. I don't know if you guys know the podcast 1619, episode 4 talks about this in detail. It's really, really interesting. And then there was like this financially driven component of kind of bringing Western medicine into these communities that were getting their care by midwives and lay healers. And of course, like we're talking way back when medicine was not very good. And at that time, when you saw a doctor, you saw a priest at the same time. That was the time of leeches, etc. And this book here, it's like a great, interesting history and book, because it talks a little bit about like witches, for example. Like they were really midwives, right? And some of the little tropes around witches, like all of these midwives had cats to keep rodents out of their space of providing care. Hence, like the image of a witch with a cat. And then the other issue was cleanliness, right? Washing hands and sweeping up and cleaning and keeping a place for care clean. This was before we really understood like bacteria, but like they had figured out that that was a way to try to keep people healthy. And so again, like the witch with her broom and her cat. Anyway, side issue. But there was also, I think, a certain amount of arrogance of, oh, those herbs, like we have real science here. And even as we developed real science, beyond the initial time I was talking about when you saw a doctor and a priest at the same time, as real science developed, we maintained that kind of arrogance of like, we don't need to, those are lowly and, just eat a healthy diet. And then it's just snowballed, right? We have this kind of unregulated capitalism and we set up these billing systems around diagnosis codes. And so suddenly, like treating disease was, reimbursed at these rates, preventing disease wasn't even considered. And again, I feel like part of that was some of the arrogance of like, oh, we do the real science, not that prevention stuff. And I mentioned already the autonomy. The other issue really is that how some aspects of healthcare were early on taken out of the hands of professionals, like, reproductive justice issues, reproductive health care, is kind of the clearest example for me, where suddenly we have, like legislators who don't know anything about human anatomy, making decisions about how do you treat an ectopic pregnancy, and they don't even know what a fallopian tube is. Regardless, like medical decision making being made by people who are not trained to make them. All right, so that was the basics, and then I slid right into some background. And I do the background also because, it's hard not, like I've been in practice for 25 years. I graduated from med school in 1991, and it's hard not to own the shortcomings of our system, to feel like, what did we do? And that's where the background I find helpful, right? Even now, when we see that there's these huge racial disparities, for example, in maternal mortality, sort of saying there's racism that's built into the structures of our healthcare, but then are we guilty? I don't know that that matters. What matters is these are the things that led us here, and maybe we start doing some problem solving. All right, so we're going to get into more details, and I think we still have time, and there should be time for questions. Kind of thinking about who the healthcare system serves, how, the details of how profit-driven systems impact patients, physicians, businesses, and community health. And then for a lot of people, we benefit from data. So I talked about the patient information in terms of not being served, the uninsured, the people who die, the personal bankruptcies, including that 77% who had coverage at the time. But also communities don't benefit, right? Compared to other places, we have higher infant and maternal mortality. We have decreased life expectancy, and we'll look at some of our comparisons to other places. We access preventive methods less, and we have less access to specialized care in much of the nation. And of course, the costs are becoming unsustainable. This is some data from the Commonwealth Fund, which you guys will find is a really awesome resource. They do great work. But like thinking about and talking about like the underinsured, people who manage to get health insurance, but actually can't use it because they can't afford it. And this is some of the references for the initial data that I think you guys had. I'm not sure if you guys are going to get to meet Steffi Woolhandler and David Himmelstein, but they're really kind of early on researchers who took on these issues and who do wonderful work, and they have mentored some of the people doing really exciting work now. Regardless, it was their work that led to this number of deaths due to uninsurance. And then this is us, comparing us to other places on the scale of life expectancy, infant mortality, higher than all these other countries that we are comparable to. And of course, maternal mortality, kind of insane. We're actually higher than areas that don't provide universal health care. And then this is ranking our mortality rate against peer nations. And this first look is up until the age of 65. And then at 65, suddenly we start providing better care, right? This idea that, you know, there's not something inherently wrong with the provision of medical care in America, right? When people have access to it, we're as good as anywhere in the world. US public spending for healthcare, for health exceeds total spending for other countries per capita. And this is, you know, public and private, although truly this is a blurred number now that Medicaid and Medicare are being provided through private coverage. We're seeing this increasing problems accessing care, having a problem not seeing a doctor, having a prescription that you just didn't fill because you couldn't afford it, skipping a test that was recommended, not seeing a specialist, although that was recommended. And then sometimes, you know, people will say, well, here in America, it's just that we access too much healthcare. We use too much healthcare, and that's why we need to put limits. That's why we need to have co-pays, because we need people to limit their unnecessary care. Most of the data says that we do not in the United States seek unnecessary care. We don't spend more time in the hospital than comparable nations. We don't see doctors significantly more than other nations. And of course, this number that we talked about, bankruptcy or illness-related work loss as a cause. And right, that's that thing I was talking about. Like if your insurance is connected to your job and then you get ovarian cancer and you can't work, then you lose your insurance, right? There's like something inherently wrong with that, the math or the system we've set up. And this is people having coverage at the time of their illness. So where does our money go? 30 to 35% going to like administration, and that again including profits and then all of the complexities of building systems that try to pull profit out. So that's where hospital billing staff and physician office staff comes in. You think about like in Taiwan, right, spends 1.6% of their healthcare dollars on administrative expense, and then we spend 30 to 35%. You know, the administrative overhead of traditional Medicare versus United Healthcare. And this is all about those, like, I'm sure you all have heard, like, people having to get authorization for tests. And back in the day when I first started in practice, if I was doing something according to National Comprehensive Cancer Network guidelines and I was, getting a routine PET scan for the staging of cervical cancer, for example, I didn't need to get pre-authorization. It was only for uncommon diagnoses, uncommon tests, or kind of making an unusual decision-making process that needed pre-authorization. Now it is routine for any test you order to need pre-authorization. And of course, this is like the growth of physicians, administrators needed in healthcare versus doctors. And, in some ways, like, I don't want to demean what these administrators do, right? Like, the billing people in my office are as committed to our patients getting care as I am. They're fulfilling a need that we've built into the system, right? Ideally, we take that need out and we let those people get trained to provide actual health care. Just other ways of looking at the same concept of administrative overhead, right? In Duke Medical Center, having just under 1,000 beds with 1,600 billing clerks, and the annual billing cost for one primary care physician being almost $100,000 versus, and these are 2019 numbers actually, in Canada, the University of Toronto, 7 billing clerks for almost 1,300 beds. So who's not served? Not US businesses, as we talked about, right? Healthcare costs are 25 to 40% of benefits that they provide. And of course, that limits their ability to compete with countries that are making cars and not having to pay for health insurance, and limits the ability of people or the freedom to set up a small business. And we talked about the physician aspect of this. This is, how much time we spend with patients versus how much time we spend doing the electronic billing record. And I kind of love this slide because it's like looking at like the number of characters per chart note. And it's like, oh, are we just so like verbose that, like nobody taught an American doctor how to write in a concise fashion? No. It's about the billing requirements. And truthfully, so much of this stuff is pulled out of the electronic record and just brought in. And I'm sure you guys have been exposed to medical records where it's like, wait, why did this patient come to see this person? What did the physician decide they had, and what treatment or test did they recommend? Like, you have to dig through the chart to try to get that information now. And then there's other places that we spend money that we don't have to. And, malpractice insurance is a huge expense. And one of the interesting things about lawsuits in the United States is that often it isn't actually, and even like when malpractice cases are determined in the favor of the patient, sometimes it's about the actual case, but a lot of times it's about whatever morbidity has occurred, the person trying to get coverage for ongoing costs of that morbidity, right? A ureteral injury that needs a percutaneous nephrostomy or something that's going to take longer. And now we're having challenges with covering the costs of that. We could talk about that more. This is a concern for lots of physicians. Hey, if we dramatically change our healthcare system, are physicians not going to be compensated in the way they have been for their training, for the time, energy that they put into emotionally, spiritually, and intellectually challenging professions? If you compare us to Canada, some professions actually make more in Canada than we do here in the United States. And certainly as we look at that, the increase in administrators and increase in profits across countries, it's not that physicians are making a dramatically more amount of money. We talked about this previously on those early slides, and here you have some references. And this is, again, another Commonwealth Fund piece of data, right? The biggest challenge facing small business owners, cost of providing healthcare coverage to employees, right? As opposed to like the things it should be, right? Competition or attracting new customers or, making better cupcakes or whatever it is that one makes. So who is served? It's people at the highest levels of these businesses, right? The healthcare insurance industry, the pharmaceutical industry, private equity, CEOs, and shareholders, right? Thinking about drug companies and, 13% in research and development, 35% marketing admin, 27%, and then of course 20% profits. And where in this is like the lawyers that they pay for the lawsuits that they accumulate? I'm sure it's somewhere in there. So where does our money go? And I have slides and slides of this stuff. These are the companies and the profit they make and their CEO compensation, right? Nobody who touches a patient ever makes $350 million a year, right? These are other healthcare CEOs, again, in the millions. And these are systems, profit and nonprofits. Do we have time for a little breath work? Let's do it. I'm going to pull up this picture so I can show you. All right. So I teach all my patients this. And what we know is, right, there's so many things that turn on our sympathetic nervous system when we multitask, when we're worried, when we're angry, when we're stressed, when we're in pain, when we're, all of these things turn on our sympathetic tone. And we know so many of the chronic diseases, including cancer, but cardiac disease, diabetes, are related to this chronic elevated sympathetic tone. So how do we turn off our sympathetic tone? How do we decrease that and turn on our parasympathetic nervous system? To me, the easiest way is a breathing exercise. We know that when we breathe out longer than we breathe in, right, that the expiration is longer than the inspiration, that automatically, right, turns on our sinus node, decreases our heart rate, decreases our blood pressure, and slows that chain of events that comes from the adrenaline, cortisol, sympathetic chain. All right, so how you do a 4-7-8 breath? You close your mouth, you inhale through your nose for a count of 4, hold your breath for a count of 7. And then when we exhale, we're going to do that diaphragmatic thing, right? Where we pull up our diaphragm, empty our lungs, we make a whooshing sound. Now, if you look at the yoga literature on the 4-7-8 breath, there is yoga literature. So put your tongue behind your upper teeth. That's yoga position. I don't know, believe this or not. My greatest belief on why this works for me is because when I'm counting, I'm not thinking. And I think that expiration longer than the inspiration. So we're going to do 2. And then some people get a little lightheaded when they first start learning this. And so we're not going to do 4 of them, but I would encourage you to learn to do 4. Lots of times I'll do a 4-7-8 breath, right before I walk into a patient's room, because it's a way for me to recenter myself, off my pager and my call and my computer and everything that's happening out here. I'm going into this room and I'm going to be there for that person, right? Anyway, so we're going to close your mouth and you're going to inhale, or actually empty your lungs. Now inhale through your nose, 2, 3, 4, hold, 2, 3, 4, 5, 6, 7, out as you next. 4, 5, 6, 7, 8. Breathe in, 2, 3, 4. Hold, 2, 3, 4, 5, 6, 7. Out, 2, 3, 4, 5, 6, 7, 8. So I do not for a moment think that 4-7-8 breaths are going to solve our healthcare system. I just think of them as a tool for ourselves. And I don't know if you guys noticed, I'm already talking slower, right? Because the truth is, we get into that rhythm. But what are the real solutions for both the United States and for us as healthcare professionals? I would argue that it's a single payer system, right? Where we take the profit part of it out, we provide care to everybody. And we'll talk a little bit about what makes that feasible. We already looked at this slide, but kind of thinking of the simplified nature of it and the idea that, everyone gets it regardless of age, income, employment, or immigration status. covered for your entire life. So in the years that preventive care matters, right? It doesn't make sense to start preventive care at age 65 when we provide care to everybody. And then of course, getting rid of all this pre-existing condition and other crap that like limits people's ability to move. And we haven't talked about narrow networks, but a lot of the insurance plans, like the reason people don't have access to care is even if there are all these specialists in this area, it's not part of their plan. So they don't have access to the people they need. How do we do it? It's not as complicated as we think, right? If we're still going to use all the same offices and all the same hospitals and just take that middleman out and change the way hospitals and professionals get their money. So getting rid of the administrative waste and then like investing in like currently, like there's so many places in rural America, for example, where like they don't have orthopedic specialists and or like, of course, OBGYN care now has gotten so fraught, not only because it's not a moneymaker, but also because, there's a lot of hospitals just aren't willing to take on the potential legal situations that they might get into. So just comparing again, like the commercial insurance, the physician proposal that we currently have. Hey, and just thinking of the simplicity that would entail. So can we afford it? Absolutely, right? We looked at the $1 trillion that we're spending on something other than healthcare with our healthcare dollars. And there's several different systems, including the Office for the OMB, Office for Management and something. I forget what it is. Anyway, they are nonpartisan and they review these. And so if we think about like how much would we save, how much would we be planning on spending, and really like all of the places, right? If we could actually negotiate drug costs, if we could actually negotiate like devices where we could save, right? This is sort of a public health survey now, a few years old, but like depending on how we phrase these questions, do you support everyone having access to care kind of questions? And this, again, this is old and we need to redo it, but like physicians, as physicians have become increasingly employed by hospitals and find themselves in these situations where we don't have the autonomy, we can't work with patients the way we want, increasing support. This idea of moral injury, and thinking about healthcare, and really like you guys are committing this chunk of your time this summer to learning, in a way, like I think you guys are doing self-care because you're thinking about, the world you want to go out in and practice and take care of people and doing what you can, getting educated. Of course, you've got your community with your group there. And one of my goals, even with talking to y'all about this, is to try to give you guys the data to be able to talk to your colleagues, talk to other people in the world about it. So I think we have about 35 minutes. I'm going to look at everybody. I have a few more slides that I could show to that aren't details so much as they are just ways of talking about things, or we could just go straight to questions. Do you guys want to go through a few more slides? Trying to look at the group of you. Sorry, my share screen is preventing me from seeing. Do you get any thumbs up, down? Thumbs up? Okay, I see a couple thumbs up. Well, just real quick, not a lot of time. But the other way I sometimes talk about this, and I've talked to church groups and other groups, and sometimes the way to think about this and phrase it for people, because it's what fits with their set of beliefs, is sort of the perspective, right? There's a philosophical perspective on why we should all have access to healthcare, right? That it isn't a commodity so much as a social service or a human right. And again, like framing this same data in a philosophical way sometimes helps people. And then I spend a lot of time talking to Rotary clubs, business groups, boards of business. Oh God, I'm showing my age. I can't think of what they're called. I'll think of it in a second. Regardless, like they're interested in the practical, like what can we do to help support us? And of course, how is it that we're spending so much money and continuing to spend more and more money, but like getting worse and worse healthcare outcomes? And even like when I talk to regular people, right? Like thinking about like a healthcare system based on avoiding sick people, right? Like that's what pre-authorizations and denials are about. When people get healthcare denials from their insurance company, we just put out some data about this, that most denials that are appealed are covered. The problem is people don't always appeal denials because there's all those things, right? If you have ovarian cancer and you're getting care, like you don't have time necessarily or energy to be on the phone. Same as like, truthfully, like my mammogram got denied and I like came so close to just paying for it because I was like, oh my God, like I'm in the middle of a move. I can't deal with like actually getting like pushed into like collections because I just didn't whatever. And I don't know where the paperwork is and I can afford it. I'll just pay for it. And I was like, no, I can't do it. I have to like, and I know, right? So many of our patients like, oh, it's $20. I'll just pay for this prescription and not push back on it. And the truth is, you know, they did pay for that. We do pay for our health care. All right, we don't need the more bonus slides. There are more bonus slides, but I'll send those to you. But they're just full of more data. So let us stop sharing screen. And how do I look at you guys? Okay, I can't see everybody. I'm screwing something up. Okay, I'm just gonna go in the order that I see hands. Kaya, question.
Hi. Oh, sorry, my voice is failing me. I just had a question. Based off of your presentation, is there a specific healthcare model that you're aiming after? I think there are like 4 famous ones. It's the beverage, the Bismarck, the insurance. Is there a particular one you want the US to move to, or is it a different model or a hybrid between the two of them?
So ours is a pretty hybrid situation, and I do have slides on that. If y'all want them, I can forward them to you too. So the one piece that is true, like we're never going to be an NHS, right? Even the VA has changed mostly because that's how our buildings exist, right? Like our universities, our hospitals, and the other care provision. So the piece that would be separate is having all the money come into the same place and having decisions and allocations happening in this central location. So in some ways it would be similar to Canada. The presumption is that we would be like Switzerland, Japan, and I can't think of the other country, but like there's a number of countries where there's an option for the private provision of care. And I suspect that we will keep that in our system, certainly for things that we might decide, well, Botox doesn't need to be covered for everybody. Like that has to be a choice. Okay, so these are cosmetic dermatologists or plastic surgeons who are going to work over here, and we're going to have a system for that to exist. And I think that always should exist. All right, Chris.
Yeah, thank you. We have a compelling argument, it would seem, or I guess we're all believers of some sense already. That said, what is the practical hope that this actually gets done? Like, if you're talking, you are talking to me. So if you're talking to me, we're putting in the 5 weeks. You guys are spending all this time, the people who are setting up this whole internship. I'd love it if there was no war. I'd love it if people didn't commit crimes. I'd love it if people didn't litter. We're not there. We probably will never get there. Is this more hopeful that we can actually get there? And
Sure.
Advocacy just to make ourselves feel good is not what I want to do personally. I want to advocate so we actually get somewhere. Can we get there?
Yes, but I can give you a more detailed answer if you like. So the thing I'd say is one, so I've been involved in this movement for a long time. And as you all know, like the language has certainly changed, right? There was never until the last two elections candidates running who included universal health care as part of their platform. And that being part of our platform to me is an evolution of change. I think the other piece that's really challenging for me as someone who's been in practice for 25 years is that certainly among my colleagues, I see a frustration with our ability to provide good care that we haven't seen before. And I think the will among professionals has changed. I mean, do I think we can do this? Absolutely. You know, how is the nitty gritty going to actually happen? I think the same way, like, I mean, you know, there was a time like women weren't allowed to vote, and we thought that that was just the way it would be forever. And they thought it would be like an impossible thing to get and do. But like, that was wrong, you know, and that didn't serve anybody. Didn't serve families, didn't serve individuals, certainly didn't serve women. And so the idea like that we just can't do things because they're hard, like, is it going to be really hard because United Healthcare has got a shitload of money? Yes. But we got a nation full of people who want access to care. And do we sometimes have to, you know, like I struggle with like, how do we build the road to get there, right? Does that mean we start with making Medicare better and fighting Medicare Advantage and pointing out to people, you know, the challenges of giving our money away to things that aren't healthcare? You know, we also, like, as a movement, have not been, I think we've always been very patient centric. And I think that's the truth is that's right. That's why we got into this business, right? To take care of people. But we left behind, I think, physicians and people who, once you get into the world and you have your practice set up a certain way, and you're just worried about like, I got to pay for my PA and I got a new echo machine and I got to cover that. And, you know, how am I going to do these things? Those physicians are people that we've never really engaged in this conversation of how can we make your lives better? How can we make your ability to provide care better? And I think we have to do that. So do I think we're going to achieve this? I don't do this for me to feel better, right? I don't give people chemo because it's to make me feel better or them feel better. I do it because I think I'm killing their cancer. I do not advocate for single payer because I think it makes me feel better. You know, the thing that you said about the self-care and me like saying being an advocate is a way to help take care of ourselves. No, I think that's taking the skills we have, taking the knowledge we have and operationalizing them, right? Putting the stuff we know and using it. Seems like we might want to have a back and forth, but we can come back to this. I'm just going to let a couple more people ask questions because we have other hands up. So Danielle, question?
Hi, first up, I want to say thank you so much for coming to talk to us today and taking
Welcome.
time to do that. I wanted
Pleasure.
to ask about what do you think are some of the unintended consequences on the job market as we move towards this single payer model? Because if you take out the middleman, that's taking out a lot of like people that work in insurance, in administration, billing, all those things. That's a lot of people work there. So how would
So
we?
every bill that's been written, like if we look back, and this is where we get into the nitty gritty of like, how do we actually do it? Every bill that's been written so far, including Sanders' bill, Jayapal's bill, back in the day, John Conyers was the congressman who was leading the movement. We always build in a provision for this. So you build in a provision for retraining for the people in the business. And the truth is, like I said, like I have never met like our billing people in my office, like half of them are like going to MA school or, you know, nursing school or, you know, want to be radiation, you know, techs and other things. Like most of those people who came into that workforce didn't do it because they specifically wanted to work for an insurance company. They thought they were getting into healthcare. So I think we have to be careful about how we formulate those bills, how we take those businesses apart, and what education and retaining we provide. But every single, bill that's been put so far has included that. I'm going to say your name wrong. Is it Merceline?
Yeah, Marceline.
Merceline.
I just want to say thank you for your presentation. I found it very enlightening. But when you were talking about one of the solutions being to get rid of the money that we spend on the administrative aspect of healthcare, what exactly does that entail? Is that just getting rid of employees, like Danielle mentioned?
No, it's like, okay, so I'm going to bring Chris's question into this. So there's a bunch of different ways to do it, right? One way is to be incremental about it. Say, so first, we are going to get rid of all pre-authorizations. And if it's on any kind of guidelines, whether they're orthopedic surgery guidelines or family practice guidelines or comprehensive cancer network guidelines, if you're providing care on this, like you don't need pre-authorization. Let's just eliminate that. Or we're going to create a separate board over here that's run by federal government or the state that's going to handle denials, right? So we could break away those pieces. But ultimately, it's about taking the insurance companies out of the equation. So there's no room for money to just go to shareholders or just go to profit. Because if you think about it, like that's the only reason to have denials that ultimately should be covered, right? It's just because you're trying to avoid paying for that care. Same as the pre-authorizations. Like, I'm sorry, like there's no such thing as operating on someone for ovarian cancer without a CAT scan. So there's like no reason for an insurance company not to do it, right? Same as like chest x-ray with an abnormality. They need a CT of their chest, so you want to know what it is, right? Like, so like some of these, like, you could think of it in different ways, but right now there were a lot of people working on like the small piece problem solving, like getting rid of things like pre-auth and stuff. Ultimately, I think though that profit motive part of it is a challenge, right? Because even if we think about like coding and diagnosis coding and billing coding and all of that stuff, and even on the physician side, having to go to a coding class, having to do all this stuff, it's because like you need to keep your practice alive. And so then you feel like obligated to like get the coverage you deserve for taking care of the complicated patients you deserve. And so, yes, then you spend all that time on the stupid medical record, making sure you put in the comorbidities and all this other stuff, because that's the only way you're going to keep your roof over your head and pay your nurse and your front staff office, right? And so if we could simplify that, right? If we could say, this is how much it actually costs to take care of patients in this part of the country when you have this kind of patient load, and we come up with global budgets and we do it in a more clear and concise way. And then we let physicians make some of those decisions on what they think the best use of that money is. I mean, I think it's like a multi-fold answer, but it's completely doable. I mean, and even like as individuals, like imagine like your personal life budget and you were just like throwing like 30 cents away for every single dollar. Or you were putting it over here and using it for something that has nothing to do with you, right? Like if you're giving it to charity, good for you, awesome. But like, think of bringing it back in and all of the useful things you could do with that. So my screen looks really weird, but to me it looks like Steven's next, and I hope I'm not picking people in the wrong order.
Yeah, I'd also like to say thank you for taking your time to speak with us today. My question, and you touched on it a little bit, with the graph comparing, or I guess chart comparing like US physician salaries versus like Canada salaries for different specialties. And I was just wondering if you had any other tips on talking to attendings or residents, as a lot of us are like medical students about like enter rotation soon. And I know with like previous experience shadowing, I noticed that a lot more like procedural based specialties seem to have like a little bit more resistance overall, since they seem to be a little bit more more compensated than like primary care. So are there like any other tips for like having that conversation with like attendings and whatnot?
So I think that there's three sides to this conversation. So the one is, I think, depending on what you do, if you're a, cosmetic-based plastic surgeon, you know, that may not be like a worthwhile conversation, but the truth is their job's not going to change because there'll always be people who can afford to have those things done. And the truth is that's who's doing it now. I think a lot as a proceduralist, as a subspecialist myself, as a GYN oncologist, I think a lot of people are in a high sympathetic tone space, right? Like, this is how I got it to work, okay? This is how I can afford chemo, and this is how I can afford this, and this is how I can afford this. So, like, just don't mess with my system. And kind of reassuring them, like, this could make your life better, right? If you never had to talk to another insurance person about getting a CAT scan covered, you know, if when you want to do a knee replacement, you're just going to be able to do it as long as you're following the guidelines. And if you know this patient has no potential to benefit from physical therapy, and you shouldn't waste the next 3 months of their life in pain, then your and that person's decision is going to go. I think talking about that, and I think the other thing is like, I never imagined that somebody else who had no medical training whatsoever could tell me what was right for my patient, right? And I think that loss of autonomy, like, I think that's the other piece that I talk to people about, is that, like, we should get to make decisions. You know, we do the research, we have the data, we take care of the people. If I'm sitting in front of someone who, like, has the worst neuropathy ever, but I can't get any of the drugs covered for her that don't cause neuropathy, like, that's just stupid. The drugs are out there, like, it's relative. So I think we have to, like, talk to people at the level of their concern. And then I think, you know, the reassurance that, like, you know, nothing's going to happen overnight. All of these things are going to be gradual, and the difference is going to be professionals, physicians are going to be involved in making these decisions, right? That this will not be a situation. Our plan, most plans, the way the budgeting is set up, all of these things are not going to be done by people who have no medical training. I think the other piece, so that was the one side of just like how you put it in words, but I think the other piece is that we have this tendency to have, like, good guys and bad guys. And I think in the world of healthcare reform, we've somehow made, you know, specialists the bad guys. And it's part of the way we use language. You know, now there's some movements to at least provide universal primary care. And there's a part of me that's like, I get that, right? That's the least expensive part of healthcare. You know, if we can just get access to everybody to have that, at least, maybe we start doing some true prevention and manage to not end up with, you know, all these things. On the other hand, like, there's something inherently unfair of being like, okay, you can go see a primary care doctor and they can do your pap smear and they can prove that you have cervical cancer, and then you don't have coverage to get your cancer treated. Like, is that the system we want? Like, I don't know. And so I think this like good guys and bad guys language has to change. And the only reason, you know, proceduralists make more money is because of that system that we've set up. And I don't think there truthfully is anybody out there who thinks like, oh, you know, my knowledge as an orthopedic surgeon is more valuable than that of a neurologist. It's not. Right. And I don't think anybody thinks that. And once you, like, get into the real world of practice, like, everybody knows everybody needs everybody. Right. And I think that part of, and honestly, I spent a lot of my years in academia. I was at Northwestern for a long time. But kind of like once you move out into the real world, like, it really is interesting. Like, that, oh, you know, I'm going to be an asshole because I'm a GYN oncology surgeon. I'm going to be nasty to the general OBGYN. Like, it's just not real life, because we all are a team taking care of people. Sorby?
Thanks for your talk. It was really interesting and I definitely learned a lot. My question was about the model of how directed primary care could potentially kind of address some of the issues that we discussed today. So things like patient cost, the administrative costs, physician salaries. Do you think that's like a good way, like a model to use in healthcare to address things that we talked about?
So, I think that there's a lot of band-aids out there. And I've talked to a bunch of people who've elected to practice in a direct primary care model. And it's their solution to solving their life, their professional issues. And so I think as an option, it's worthwhile. I don't think it solves our national problem, right? Because like as an individual, can I put out a shingle and make a relationship with a lab, and I just send people to that lab and people give me a small amount of money to take care of them. But again, like as soon as they have something that needs something else, I've run into a problem, right? As soon as I diagnose with cancer or something else or something that needs hospitalization, like then I'm challenged and I might not have a relationship with the hospitalist here. And so as an individual physician, I think it's a solution. For patients, I don't think it's a great solution. Because for them, the negotiating of, okay, I just pay you a concierge fund, but then for everything else beyond that, I have to work the way through my insurance companies. Again, for a physician, like, yeah, like I could not be a direct gynecologic oncologist, even get rid of the issues of like, where do I give chemo and where do I do an operation and all this stuff. Like in my office, like it would be impossible for me to expect my patients to do all the pre-authorizations for the CAT scans and the other studies they need. Like there's a certain amount of expertise you need. There's a time and energy need. It's not a reasonable thing to ask of somebody getting chemotherapy. And so I think direct primary care is a band-aid solution for individuals who are trained professionals and can't find a way to practice that works in their lives. And so I support them like fully for doing it, but I don't think it's the way to solve our problems. And of course, like you're at saying direct primary care, that's slightly different from the thing I was discussing when I answered the other question of creating universal access to primary care. That's like a different thing, right? That people are trying to do. And again, like I totally get it. It's a good way to at least introduce this concept. A lot of people think if we do universal primary care, because that's the in quote cheap part of healthcare, that it'll drive insurance companies out of the business, because like that's how they make their money, because they get money for a bunch of people who don't need that much care. They just need like their mammogram this year. So like all of those are like concepts like on a way to, it's like an incremental way to get to everybody getting all the coverage they need for everything they need. Gabriella?
Hi, yes, thank you again, and I apologize for misspeaking in your introduction.
Oh, no worries. I'm sure you have like some old thing from PNHP. I've had a lot of mobility. It's all good.
Yesterday, in one of our lectures with Dr. Dolkart, we watched a video of Ronald Reagan kind of doing some like fear-mongering propaganda work into classifying single payer as this socialist movement that's going to take autonomy away from physicians, and then how far will the government reach go, and all that kind of stuff. And I saw in your presentation the chart of how a lot of physicians at this point are now in favor, like we've reached over that 50% of being in favor of transitioning over to a single payer model. So when we talk about advocacy and targeting that advocacy work, is it still physicians and those in the medical care system that we should be reaching out to most with this advocacy work, or is it general populace? Is it directly reaching out to legislatures? Like, what's our best mode of action for our advocacy work moving forward?
That's a wonderful question, and all of the above. So as you know, the president-elect to Physicians for National Health program, like in that role, like I strongly believe we have to activate physicians. We have to, activate our voices. We have to make our lives better. We have to make this a profession that remains like the amazing job it is. And I think we've made a bunch of mistakes. I mentioned the the us and themness of primary care versus subspecialists. And I think sometimes people are critical, say, for example, of the direct primary care model because that doesn't address the needs of the population. And to me, like, it's ridiculous. Like, doctors are part of the population. We get to address their needs too. But the other thing I think that we have to do is we have to build coalition, right? So we have to partner up with the reproductive justice movement, where to me, that's the clearest example of like non-professionals making decisions about shit they have no fucking idea about, right? And, we've lost, talk about sanctity of patient-physician relationship. You have to report every miscarriage that happens. You have to report every, some of these, conversations, and those are our natural allies that we haven't really moved on for a number of reasons. Unions, another like natural ally for us that we have to build coalition better with. But I also think like the truth is like now as we're looking at legislation in terms of upcoding and inaccurate billing, like it's Republican senators who are kind of interested in it. Because the truth is nobody wants somebody to steal your money, right? Everybody who like gets a paycheck sees the money right now on that paycheck that's going to Medicare. And to imagine that 30% of that money that you just gave is like paying some like CEO $500 million, like it's infuriating. And so I think we have to try to take it out of that language we put it in. And that's a big, long conversation. And fortunately, like there's been so much more movement on this that I think we're engaging like, ASO and some organizations that think about languaging and how do we, reach people? How do we talk to regular people? Like when you basically feel okay, like most people don't even think about it. Like the number of like nurses, teachers, police officers, fire people, like who thought they had great insurance until they got cancer or until they found they had a BRCA mutation and they just needed their ovaries out and they didn't have coverage for it. I mean, I think helping people understand, and the truth is like now everybody's got a story, like somebody who broke their leg on a skiing trip and like then they got these crazy bills because they were out of network, right? Like we have to, I think everybody has to be a part of this problem because truthfully it's a solution for everybody. The only people who like really, I don't know, this is going to sound super lefty and let's face it, I'm a super lefty, but like it's politicians who like enjoy just the plain old power and they're not there to solve problems. And for them, like the power is like, I'm going to get a bunch of money from insurance companies and then I'm going to stay in office and enjoy my power. Like those people were not going to get on our side. Right. And then I'm sorry, like whatever the guy's name is who runs United Healthcare, he ain't going to be on our side ever either. Right. And so those people who we can't, like, I don't feel a great deal of energy, but there are plenty of Republicans who are very interested in making sure that their constituents in rural America get healthcare. Right. And so just building bridges on the things we have in common and not focusing on the things we don't have in common, to me, is how we think about it. And then the truth is we have to get better information, right? Somehow in the single payer movement for decades, we thought like, we shouldn't talk about abortion because now the truth is the whole Democratic Party thought that too. And it was only when like actually we took rights away from people and their own bodily autonomy that like we were like, oh shit, you know what? Most people think it's okay to control your body. Most people think it's okay to like pay for contraception or actually think we should, right? And the world changed. So I don't know, I think we have to sort of engage those organizations that can help us think about how to talk about things. You're welcome. I'm going to say your name wrong.
It's Nehemiah.
Nehemiah, got it. Awesome.
Yeah. Thank you so much for being here with us and for sharing. I really appreciate all the information you presented. And a question I have is I can kind of predict, and this is probably an argument you've heard, and I would love to hear your response to it, that folks would feel that if we were to transition to a single payer system where the government has negotiated the price they're going to pay for services, pharmaceutical drugs, and things of that nature, people will feel that the innovation that's kind of driven by the free market system won't be there, and so we'll just have generic versions of certain things, and the innovation will be stalled. And I would love to hear your response to that.
Yeah, that's a awesome question, and it comes up a lot. So great question. So several things. One, when I think about everybody from like DeBakey with his pickups, and now like Ligature or robotic intuitive, like the robotic surgery machine, like, did those evolutions happen solely because people wanted to make money? Or were there people who actually like thought it would be cool and interesting to make surgery better and to make it safer and to make it more efficient? I mean, I guess I would argue that this is America and that innovation will always be there, that it's not only the dollar that drives us. And if you think about academic medicine, for example, and the research that goes into drug development and understanding disease and understanding obesity and understanding some obscure receptor that somebody spends their entire career exploring, like, I think to say like those people are clearly not driven by profit or finance, right? Like otherwise they wouldn't work for Northwestern or, Ohio State or whoever it is. And so I think that it belittles kind of the intellect and creativity of our scientific communities. And if we look at, for example, just like drug development, and Marcia Angel, who was a prior New England Journal of Medicine editor, has some great, she has a great book, and then she's written some great articles on like the drug companies and thinking about innovation. Like innovation does not happen within drug companies, right? All of the drugs that are innovated, that 13% of their budget come out of academia or nationally paid for research like the NCI and the NIH. And then it's the late stages and the Me Too drugs and the later evolution that happens here. So that is not actually the home of innovation. Same as if we think about like so much of our advances in medicine and healing came out of the military, right? The trauma data, some of the newer surgical techniques we're using, taking care of traumatic brain injury. Again, like that's a nationalized system that somehow manages to do some of the best research that happens in America and drives us forward. So I think it's one of the falsehoods of kind of this belief of what drives people to innovate and to be creative. And to want to cure cancer, right? Like the people who, were children and lost a parent, and that pushes them into the world of becoming the next, greatest cancer researcher. I think we'll still do that. I think that's, I don't know, part of the wonderful thing about being a human being. And I think, the other part of like the way we talk about it, right? Like government funded, it's not really government funded, right? It's like all of us who pay taxes in any single way who fund the system. And as we write the laws and as we set up the program, like being extremely thoughtful about having patients and doctors and nurses be on every board, every part, every step of these decision-making, elements will there be struggles along those pathways? Will there be boards that make bad decisions that then have to be revised? Yes. But like, I assume that we will always be advocates forever, right? We'll just hopefully be advocating for better things, right? The nitty gritty as opposed to like the plain old access to healthcare. I
Thank
think
you.
we're close to end. You're welcome. Nurali?
Hi, Dr. Singh. Thank you again for your presentation. My question was more so related to the primary care physician workforce that we currently have. I think we were talking about this on Monday on a lecture where we know that in US we are still lacking like enough primary care physicians. So do you think like transitioning into single payer healthcare system would put like added burden on the current workforce that we have, especially when it comes to primary care?
So, healthcare, this is a great question. You guys all have like all the good, hard questions. It's a real problem. I mean, I spent the vast majority of my career in like DC, Scottsdale, Chicago, New York City. And then suddenly I moved to Norfolk, and then you know what like lack of access to specialists and primary care is. And then you go to Roanoke, where I did locums in Green Bay, Wisconsin. And, like there's no like choosing a GYN oncologist. There's one available to you. That's where you go to. So do we need dramatic change? Yes. Oh my God. And it's not just like med school spots. We need residency spots, right? We need to like evolve the way we do this and the way we provide education. And I spent some energy and time bashing in, the insurance industry. I'm just going to do a little AMA bashing, right? The AMA is the biggest organization that was supposed to advocate for physicians, and it has served us in no meaningful way other than like in these narrow ways of managing to make sure that we get paid enough-ish, right? But certainly on things like foreseeing healthcare, demand and advocating to have more med school spots and more residency spots. And, I think the challenge now in all these communities is, having advanced practice nurses and physician's assistants being put in positions that they are not trained for. And they are not adequately supported by physicians. I think it's going to be a lot of energy and work. And yeah, our workforce is going to have to be dramatically changed. But ideally, we could do that, right? Ideally, it was very interesting to me. And again, like I can Kaiser bash also, but Kaiser does some things well. And for example, when the pandemic happened, and I was operating in Virginia at the time, and like orthopedic surgeons and urologists, like for a period of time, weren't operating because we weren't doing any elective procedures. Whatever, Kaiser trained them all to like be hospitalists. Short term, not long term, short term, right? And I don't know, I'd rather go to a hospitalist if I really needed to. But, did the urologist cover the basics okay and make sure the antibiotics got started and wrote the orders and got the right specialists involved? Yeah, you know what? They can, because you know what? They're doctors. They're smart people who learned how to learn a long time ago, and they've been learning their whole careers. So, I think it's going to be work. It's going to be something else we have to work on. I think we totally have the capacity. And this is like the best job in the world, right? You get to do something that's meaningful. You engage with human beings on like the things that are most important to them. Like for me personally, like being a GYN oncologist is the best job in the world, right? Like you deal with people, you talk about like the things that matter, life and death, their fertility and their ability to have children, sex, right? Their relationships in the world, their identity, their gender identity. And it's like one of the few professions where like, is there the technician part of it? Yes. Is it great to like cut out a cancer and feel like solved, done, cured? Yes, that's awesome. But the truth is, the thing that I appreciate the most is that who I actually am, my experience, my age, my life experiences, they matter to the patient, and together, my experiences and their experiences can get us to a place where we give them the best, longest quality life we can. And so there's no reason everybody in the world shouldn't want to be a doctor, except for the job kind of sucks right now, and we got to do some work to make it better. But I mean, I think if we got back to where we were, there's no reason we couldn't easily build a workforce. I mean, look at you guys are super smart people who are thinking about these things, who, want to be in the workforce. So you're the hope for us.
Thank you.
Awesome. So I think you guys have other stuff, I assume. And I think I will be back with you guys for evening session, kind of close to the end of time. And between now and then, please, you have my email. I think it was on the slides, but it's just my full name, Diljeet K. Singh, with the middle initial in there, no spaces, no dots, @gmail.com. Email me questions, stay in touch. If the slides or something else you think of questions, or I have questions about references and things like that, totally happy to fill in the blanks.
Dr. Singh, that was marvelous. Thank you so much for sharing your thoughts with the group here. We're going to probably take a break and come back maybe at 10:30. How does that sound? And lots to tackle.
Awesome. All right. Take care.
Thank you.